This is Raby. This is an update of coronary stenting and how to manage antiplatelet therapy with coronary stenting in 2019. Most of the data I'm going to show you are from studies in the last 10 years, as well as the current American College Cardiology, American Heart Association guidelines of how to manage antiplatelet therapy in the coronary stenting era. Okay, so as a background, coronary stenting provides a kind of scaffolding to keep coronary arteries patent or open after a balloon angioplasty. The advent of coronary stenting has substantially reduced abrupt closure and restenosis after balloon angioplasty in coronary arteries. It is less invasive, lower risk, and has a much faster recovery compared with coronary artery bypass surgery, and hence has become the most common way to revascularize coronary arteries in 2019. In addition to just plain stenting, drug-eluting stenting has further reduced restenosis. The reason it does that is it curtails the body's ability to create scar tissue within the stents, but at a cost in that it delays helpful re-endothelial tissue deposit. That is, the stents remain essentially bare metal inside the artery as blood goes past them. This increases the risk of abrupt stent thrombosis if you're not on dual antiplatelet therapy, and therefore drug-eluting stents require prolonged dual antiplatelet therapy. The cessation of dual therapy less than 12 months after its inception, until recently, was associated with approximately a 6 per thousand rate of abrupt stent thrombosis. This is 2011 data. As I will show you, this has changed. The causes of stent thrombosis include why you had the stent in the first place. That is, if you had an acute coronary syndrome presentation, such as an ST elevation MI, a non-ST elevation MI, or unstable angina. If you are diabetic, if you happen to have poor LV ejection fraction, if you happen to get a first-generation drug-eluting stent, that is 2003 to 2010, those are the ones more prone to stent thrombosis and more prolonged delay of endothelialization. Stent undersizing, relatively small stents for an artery size. Stent underdeployment, stent the appropriate size but was not stretched to be as big as possible. Smaller stent diameters, 2.5 millimeters or less. Longer stents, stents put in bifurcation lesions where there's a giant fork in the artery, or in-stent restenosis, stents that have already re-narrowed and have had to be reopened again, either with a balloon or a second stent. Those are all factors that make the possibility that the stent will abruptly clot off more likely. The 2011 ACC, American Heart Association guidelines, therefore suggested that if you presented with an acute coronary syndrome, STEMI, NSTEMI, or unstable angina, you would get 12 months of dual antiplatelet therapy, aspirin, clopidogrel, or one of clopidogrel's cousins, prasugrel, ticagrelor. That is a recommendation both for bare metal and drug-eluting stents, even though drug-eluting stents are the more vulnerable for abrupt stent closure. In patients who have stable angina or a positive stress test, that is non-acute coronary syndrome presentations, bare metal stents, 30 days of dual antiplatelet therapy. Drug-eluting stents, 12 months. And that is based on the studies that I have quoted for you below on the slide. Now, new generation drug-eluting stents, those developed after 2012, seem to be causing much less delay in the healthy endothelialization that occurs afterwards. They cause less inflammation. So these stents heal more quickly and develop a layer of carpeting that covers the metal away from the blood as blood goes rushing by more quickly. Therefore, they are at lesser risk for stent thrombosis and need shorter dual antiplatelet times. Trials using only 3 to 6 months of dual antiplatelet therapy, which are quoted for you down at the bottom of the slide, showed no increase in stent thrombosis, no increase in ischemic cardiac events, except in people with acute coronary syndromes, which still should get prolonged dual antiplatelet therapy. There is also less incidence of major bleeding, not surprising because you're on less antiplatelet agents, and have lower mortality overall. The reason you have lower mortality is less bleeding. You are less likely to bleed in your head or have a giant hematoma. Overall, the cardiac risks are about the same unless, once again, you presented with an acute coronary syndrome, in which case prolonged dual antiplatelet therapy is still recommended. The newer generation drug-eluting stents may be treated with as little as 3 to 6 months of dual antiplatelets, but 12 or greater months if you've had an acute coronary syndrome. Why? Because under those circumstances, there are fewer MIs, comes at a cost of more major bleeding, and possibly overall higher mortality. But the recommendations are still, because of the higher MI rate, that you should be on 12 months. So how do we decide who gets longer dual antiplatelets and who gets shorter ones? Okay, so if you have had an ACS presentation, as we've talked, multiple prior MIs, extensive CAD, that is, you have a stent in one vessel, but the other vessels are quite diseased as well, diabetic, stage 3 chronic kidney disease or greater, smoking, or you've had coronary bypass surgery and the intervention was on vein grafts. Those are all patients in whom the risk of dual antiplatelet therapy, that is excess bleeding, is worth it for the benefit of reducing abrupt stent closure and further ischemic events. Also, technical risks for stent thrombosis, including a lower ejection fraction, an older stent, again, stent undersiding, under deployment, small stent diameters, 2.5 or less, bifurcation lesions, and prior in-stent thrombosis or stenosis. Those are all patients who should get a year rather than 3 to 6 months. Shorter duration antiplatelet therapy is recommended if you have a history of bleeding, ulcers, cerebral bleeds, etc. Women seem to do better with shorter antiplatelet regimens than longer ones because of their higher risk of bleeding. Relatively thin people have a higher risk of bleeding. Anemic people are more likely to have morbidity if they were to bleed. People on chronic steroids or non-steroidal anti-inflammatories more likely to bleed on antiplatelets, and those are factors that favor shorter dual antiplatelet times after a stent. Okay, so there is the DAPT scorecard, which I've provided for you here. Age is also entered into it, cigarette smoking, diabetes, myocardial infarct, prior coronary intervention, stent diameter, what kind of drug-eluting stent, all are factors that help you obtain a score. A score of greater than 2 is associated with a favorable benefit for prolonged dual antiplatelet therapy, less than 2, shorter periods of dual antiplatelet therapy. So the 2016 guidelines, Class 1 indications, are as follows. Everyone who has a stent should be on an aspirin. 81 milligrams a day seems to be sufficient. Those patients who present with acute coronary syndromes, STEMIs and STEMIs, unstable angina, 12 months of dual antiplatelet therapy, whether they are bare metal or drug-eluting stents, unless there is a contraindication. High risk for bleeding, relatively thin people, prior strokes, female gender possibly, all factors. You should be on 12 months unless there's a really compelling reason. Being female is not a good enough reason, but a risk of prior bleeds and certainly cerebral bleeds would be a reason. If you just presented with stable ischemia, that is stable angina or a positive stress test, 1 month of dual antiplatelets for a bare metal stent, at least 6 months for drug-eluting stents. Tailor longer therapy according to other risks. That is, the technical risks we talked about, long stents, bifurcation stents, history of restenosis, etc., and other factors that we've talked about, such as smoking, diabetes, renal failure, etc. We have stopped dual antiplatelets with as little as 3 months in patients who've gotten into trouble or need urgent surgery, for example. But 6 months is now the new standard. And that is my talk. Thank you very much for your attention.